Right, ladies and gentlemen, so we have come to the another teaching capsule today. So we are going to talk about assessment of falls. Let me introduce our speaker, Dr. Barana Millavitana. He's a resident physician, Provincial General Hospital, Kurnagar. And on a personal note, I have a great privilege to working at co-registrar. Over to you, Barana.
Thank you very much, Chapa, for the kind word of introduction. And I would like to thank Ceylon College of Physicians for giving me the valuable opportunity to talk to you about the assessment of falls in elderly. Actually, what I do today, because I think most of you will probably have joined yesterday for our pre-congress session where we talk about frailty, falls, and sarcopenia, and where actually I talked on prevention evaluation of falls. So what I do today is just start with some brief introduction, then I'll discuss uh, probably two cases, and there I go in detail to the basic things like we have to do when the assessment of falls in elderly. So it's basically case based, and we will probably I'll talk to very basic things which will be necessary not only the geriatric trainees or geriatric diploma or the geriatric MD trainees. This is for all junior doctors. This will be helpful. Right. So in my talk, just to completeness, I'll just touch on some things which I have told yesterday, and where I just give some introduction, risk factors, and the basic theory part of evaluation. Then I'll discuss the case scenarios and one scenario in detail, and then the second scenario I'll give you using the knowledge you had from case scenario first. You can actually develop the plan for that patient. So falls and falls related injuries is a common serious problem in older people, and not only the community, it's residential care and hospitals, and long-term consequences to an individual is to a family is very much high, because it can cause distress, pain. The injuries can cause like lacerations or abrasions, and it's ranging about the minor injuries to major injuries like fractures, hip fractures, which can lead to increased morbidity and mortality. Further, falls cause a lot of psychological impact to the elderly, which cause loss of confidence as well as the loss of independence of an elderly person, which lead to social issues like social handicap. And further, we treat a lot of patients, elderly coming with falls, especially with hip fractures, according to the guidelines. So we are doing surgeries within 48 hours. It is very costly business. So if we evaluate falls, probably falls with minor injuries, or if we evaluate patients who are at risk, and we can save a lot of money for our country. So fall is a sudden unintentional change in the position which causes an individual to land at a lower level on either on an object or on a floor. So there are different types of falls. Basically, if you think about younger people, we talk about accidental falls, like fall from a height. So these young patients are low risk. Why they are falling? Because of the environmental hazard or external mechanical force, which is causing the fall. But when we talk about elderly, we are talking a lot of things about physiological. So what are the physiological? So it is the patient with some advanced identified risk factors. So elderly patient like Parkinson's disease have high risk factors for falls, and those falls can be anticipated. As well as the patients with more elderly patients, fit, robust, non-frail elderly, they are low risk, but unexpectedly they can develop falls like syncopal attacks, seizures, strokes, or any acute illness which lead to falls in elderly. So We are mostly concentrating about falls, the physiological falls in elderly, as well as some accidental falls. So community dwelling in individuals, the elderly can develop about 25% of people can develop mechanical falls. It's due to slipping, tripping, or stumbling like thing. But when we take about young people, if we think that young person in similar situation, whether this young man will have a fall, probably not. Why these people, the elderly, also having accidental fall? Because they are having some risk factors like gait problems, mobility problems, those things. So there is some saying, because the external factors seldom cause the sole cause for the elderly patient's fall. So we have to think about when a person, the old age coming with falls, we have to always look the factors which related to fall in this patient. It can be intrinsic, it can be extrinsic. So why these people are falling in? Because physiological changes, the pathological changes, so those things are adding up the vulnerability to elderly. So if you think about the physiological changes in elderly, there are the deterioration of neurological, visual, as well as muscles. So neurological, like increased reaction time, decreased proprioception, the visual changes like decrease the accommodation, dark adaptation, as well as most important thing, we talked like half day yesterday, the sarcopenia, the frailty. Those changes cause more vulnerability to falls. As well as because all these things which change the gait pattern. So elderly, slower gait and decreased stride, arm swing, and bit of forward flexion, and the increased flexion at knees, shoulders, as well as more lateral sway of the patient. So the pathological processes, like these people develop osteoarthritis, which can cause joint instability, pain, and wasting of quadriceps, and weak dorsiflexion. So various sort of physiological plus pathological changes in our systems based in musculoskeletal, neurological, and other systems cause problems and more vulnerable to falls. So falls is a geriatric syndrome, as we said yesterday, because this is due to diminution of functional reserve due of orthosis. So various mechanisms to keep upright position is impaired with age, as well as because of that, the vulnerability increase, and patient is the minor accident or active disease process or adverse pharmacological stimulus, like small thing can change a drastic thing which can lead to fall. Right, falls are multifactorial, and as I mentioned here, so there are intrinsic factors as well as extrinsic factors. So intrinsic factors are like age-related changes, visual and hearing problems, the medical conditions, extrinsic medications, inappropriate devices, environmental things. So when we are evaluating and assessing a patient who's coming with fall, the important thing to look at these intrinsic factors and extrinsic factors. So I just say these things in detail because when we are assessing the cases, it's very important. So what are the intrinsic factors? So aging per se. So as I said, like patients above 65 have the risk of falling like about 1/3, like about 30% risk of falling per year above 65. When it comes to 80 years or more, they are having high risk of falls, like about 50% chance of falling per year. So mobility is poor mobility is one intrinsic factor. So cognitive impairment, continent problems, the comorbidities, sensory deficits, nutrition, and the emotional and phobia, anxiety, depression, those things are some intrinsic factors. So extrinsic factors, which actually medications, any medications like sedatives, sedatives are causing falls. It's a high risk. The polypharmacy, lack of exercises, the immobility, lack of exercises cause physical deconditioning, and those is adding up to this. And the other things like nutritional problems and environmental hazards. So environmental factors, always when we are assessing elderly, we have to do the home visit as well as assess the patient at the home. So environmental factors like dim light, the glare, the bed height, carpets, rugs, wet floors, those things, important things in environmental important factors. So medication can cause falls. Right, now we come to evaluation of falls. So who needs evaluation? So any patient who's coming to us with a fall is important. And any patient who is coming to us with recurrent falls, the recurrent falls means either 2 or more in 6 months, or even less or more than less, the more falls in past year we have to. So those patients are coming with falls. The other group is the patients who are having postural instability, the mobility issues, balance, they are high risk of falls. Because those patients, the primary preventive strategies is important. Right, so evaluation of falls is multifactorial. So what are the things we are going to do? First, the history. So detailed history regarding falls. And then the functional ability of the patient as well as psychological aspect of the patient related to the falls. And examination wise, we have to see postural instability, postural issues, balance, mobility, muscle weakness. So visual impairment, so urinary incontinence or the urinary problems, we have to assess the osteoporotic risk, the fracture risk of these patients, and home hazards. So history, the falls. So how are we going to assess the fall? Basically, the location of the fall, circumstance of the fall, associated symptoms, and the medications, injuries, and fear of falls. And basically, we have to go for detailed history. And examination, we have to do routine physical examination, systemic examination, cardiovascular, neuromusculoskeletal systems, and then lying standing blood pressure, very important. And then formal assessment of gait balance, time go up test. I will mention those things during my talk, and visual and hearing evaluation, and the other stuff like whether there's any acute medical problem or any acute mental problem like delirium, and then pain assessment and sites of injuries. So investigations. So we have to rule out anemia, infection, dehydration, and we have to see whether there are any cardiac problems like MI or arrhythmia, so ECG, Holter, radiological investigations, tilt table test, troponin, whatever. Right. So we'll come to the most important part of this talk. So that is the clinical scenarios. So this patient actually about 4 to 5 years back, which I have involved in the management, which she had like multidisciplinary team approach, as well as she's currently living without any falls after the management. So I start with the current situation of the patient, and then I go back to the history. So she's Mrs. S, 72-year-old lady from Minuangoda. She presented to our medical outpatient clinic of the base hospital with postural dizziness, and she had multiple falls for 2 months. Actually, when I was assessing this patient, that was 2015, is around March, February, like. So it is like the managed case. So when she came to me in 2015, she had first fall in early December of 2014, and early 2015, she had a lower respiratory tract infection. And she was admitted to a teaching hospital, and after treatment of she had the pneumonia, she was discharged from the hospital. after about 6-7 days of admission. And since discharge, because she had a fall before admission, but since discharge, her main complaint was she was more dizzy. She was dizzy most of the time of the day. And after coming home, she had several falls, but fortunately, she didn't have much injuries. And some falls occurred while she was getting up from the bed, and some of the falls while she was walking. And she was able to recall the event. So that means she didn't lose her consciousness. She didn't have any vertigo, chest pain, or palpitation just before a fall or during the fall. And she had no serious injuries of the fall. So in the detailed history, so she had recurrent falls. So she had falls before the acute illness. So after the acute illness, she had multiple falls, which actually precipitated by dizziness as well as no other precipitating factors, and she didn't have any syncope. So her background history. So she was diagnosed with hypertension, type 2 diabetes, osteoarthritis of the both knees, ischemic heart disease, and chronic heart failure. And this was the discharge drugs from the teaching hospital in 2015 January. So you can see she was on lot of drugs. So according to this, she was discharged on 17 drugs. 17 drugs. You can see it's like 2015. So 17 drugs, as well as she was continuing same drugs until she met me with falls. So when I did her functional assessment, so she had more difficulties in mobility and self-care. She was able to walk, but she had some difficulties because she was hauled into the furniture and walls. And she had problems with self-care, the washing and dressing, but she was independent in eating and drinking, and no continence or cognitive problems at that time. And she was very anxious because a person elderly falling several times, and definitely very anxious because for injuries, as well as that prevents her mobility. So she's chair-bound, bed-bound mostly, and remain inside the house, bit of socially handicapped, though she lived with the family, and she is more dependent on her children, so her daughter and the grandchildren. So examination. So when I did the examination, she was conscious and alert. Abbreviated mini-mental score was 10 at that time. She was not depressed. And there was no pain and rest, and no evidence of significant injuries. And she was averagely built. So her weight like 57 and height was 157, and her BMI was 24. So she was her physique was okay, but what she said, she lost some weight. She lost some weight just after during the hospital stay, as well as after coming home. But that is not so significant. And she was not pale, and she had mild edema, leg edema. Her cardiovascular examination, heart rate was 50, regular, and I checked her supine blood pressure and as well as standing blood pressure. You can see supine blood pressure was 100/60 and standing blood pressure was 80/50. So she had no murmurs, and her rest of her examination, system examination, respiratory abdominal examination was clinically normal. And the hearing assessment, like whispering, and so she said slightly impaired, but not affecting her function. Vision was satisfactory. Mainly she had difficulty in reading small prints. She was not using any glasses. Neurological examination, cranial nerves and the Cranial nerves was normal, and the upper limb, lower limb, neurological examination, no focal neurological signs detected, no cerebellar signs. But when I assessed her gait, she was walking with broad waist, short step with wobbly gait, and she walks holding to the furniture. Her muscle power assessment, it's a grade 4 weakness, and she had predominantly proximal muscle sort of wasting and weakness. And she had bilateral osteoarthritis of her knee joint with varus deformity, and she had mild distal sensory neuropathy, but no foot deformities, no ulcers detected. So these are her basic investigations we did. So in her basic investigations, her hemoglobin was fine, like to a lady with this age, 10.9, and she was not having any active infection at that time. Her electrolytes was normal, and her random blood sugar was 76. She's on diabetic medication, and random blood sugar was 76. I felt a bit low. And her thyroid profile, liver profile, as well as lipid profile was satisfactory. The other investigations, we did a chest x-ray with no cardiomegaly, mild cardiomegaly. And the good thing, though she had multiple x-rays, I didn't find any fractures, so all healed fractures. And ECG showed sinus bradycardia of rate of 50, and echocardiogram slightly reduced ejection fraction of 50 with mild dilated LV with left ventricular hypertrophy. Okay, now after doing, because I said I was fortunate, that this patient was fortunate to get the input of multidisciplinary team, and I was able to get the help of the physiotherapist, to assess her regarding falls. So physiotherapist did her assessment by herself. So I mentioned my assessment previously. So I just, from now onwards, so I will give you the physiotherapist assessment as well as the occupational therapist assessment. So physiotherapist did her assessment independently, and her finding also, the patient was able to walk independently to a short distance, but holding walls and furniture. And she recognized, when I was examining her, I didn't find any pain in her knees, but the physiotherapist catch that she recognized this patient is having mild knee pain of both knee joints, which was dull in nature and which was aggravated by walking. And even a small distance and climbing stairs cause pain. So in this visual analog scale of pain assessment, she rated as like 4 to 6. And this patient is unable to squat on the ground. So these are some findings of physiotherapists of her mobility or legs. She has done the upper limb examination and mentioned this patient had right arm dominant and right-sided shoulder pain, basically worse when she want to reach some object above the shoulder level. Again, visual analog scale of 4 to 6. So the good thing here, the physiotherapist has detected, which I have not detected in my medical examination, where she had pain with ambulation as well as pain when she was doing some activities like walking, climbing, as well as when she was reaching to an object. Her objective assessment, the physiotherapist, the varus deformity with bilateral knees, quadriceps wasting and weakness, and the wobbly gait with toe heel pattern. When she palpated, what subjective assessment was confirmed with tenderness in the medial side of the knees, as well as tenderness over the bicipital tendon of the right upper limb. And these are the range of movement and power detected by the physiotherapist. And shoulder joint is right side, the range of movement is less because of the pain. Knee joint is both sides 90 degrees, and power is like for in basically shoulder and knees. So it is basically the power is affected. So she did Burke balance scale, which I'm going to discuss these things in my next few slides. The Burke balance scale, out of 56, she reported it's 25. The functional reach test of upper limb, it's 10 centimeters. So ideally, if it is more than 25, that is the false risk is low. If it is less than 25, that means false risk is high. And she has done the time up and go test, which she recorded 40 seconds. So any patient, like if more than 12, 13.5, like if more than that, the time go up test is high risk of falls. So I'll discuss these things in detail, because these things very important when we are assessing in falls. So this is the visual analog scale which she used. This is very important part in geriatric medicine. Any elderly patient who's coming with pain, and if you think some condition which can cause pain, we have to at least use visual analog scale and scale, ask from the patient, give where she stands. So according to our patient, the bilateral knees and right shoulder, the visual analog scale suggests she had moderate to severe pain, but it's mainly while she is moving. So occupational therapist did her management assessment and home environment assessment as well, and where she detected these findings. So occupational health, basically occupational health therapist, they look at performance issues of a patient. So day-to-day activities, and she has assessed these things which is important to a patient. So as medically, we don't think much of these things as important, but when we think about the patient side, these are very important things for a patient. So she has assessed combing hair, wash back and feet, put on about blouse, and stand up from lower chairs and bed, sit and stand up of squatting pan, because they had squatting type toilet, and how she was able to open close taps, and risk of falls in bathroom and toilet. So that is very important, because maybe wet bathrooms, and risk of falls at nights. So she did the home environmental assessment as well. So this patient is living alone in her house, and she is a widow, and her daughter is actually helping, and daughter and grandchildren, they are around. And there is one step to enter the house, and 2 bedrooms, and she had tile floor. There is an attached toilet to the house, but squatting type toilet, and few rugs and excessive furniture. So these are the things detected by the occupational therapist. And occupational therapist has used, these are scales they use for their assessment. And this is Canadian model of occupational performance, where occupational health therapist look at 5 important things: indoor mobility, personal hygiene, cooking, finances, and socialization. And she looked at the importance of those activities to the patient. So it is rated at 10. You can see a patient has rated almost all her activities like 7, 8, 9. So those are important to the patient. But the satisfaction of and performance. So performance-wise, the patient mentioned like the important activities out of 10, patient had a lot of problems. So patient has some difficulties in finance issues, socialization, and the indoor mobility, cooking, and everything below 5. And satisfaction about the patient. The patient is actually hardly satisfied about any of these activities, the current status which she is performing. So the important thing is here. So we have to always think about the importance of the occupational therapist, physiotherapist assessment, because they look at the important aspect of an elderly patient, which is important to the patient, and patient's performance, patient and occupational therapist can grade and satisfaction as well. So families and carers, so and social history. So she has one daughter. So as patient is living her own house, the daughter also living in same house with the patient, and patient's son-in-law is a clerk in a private firm, and two grandchildren and a daughter. Daughter is very busy with the children's activities, and the mother has no income and she has to depend on her living. So it is a long story, and because all these assessment, I have listed the problems. So the medical issues which I have detected during my assessment, she came with recurrent falls. She had multiple comorbidities. She has multimorbidity, and she had polypharmacy, seems to be inappropriate, and she has painful osteoarthritis. She had right shoulder bicipital tendinitis, and she had some impairment in hearing and the vision. So this elderly patient with multiple falls, when we do the medical assessment, we have got several problems. So when I put these problems with all the problems together using our intrinsic and extrinsic factor categorization, where we can see, so there are, she's a recurrent faller, there are intrinsic factors and extrinsic factors. So age-related changes, so she's elderly and she has OAs of the knee, so visual problems, she's having medical issues like multimorbidity, postural drop, bradycardia, and low blood sugar. And the medication, she's on a lot of medications and no proper assistive devices. She had problems in her toileting, as well as there are environmental problems also there. So her intrinsic factors, again, she had like sensory problems as well. She had some the neuropathy in the lower limbs, and recent hospitalization due to lower respiratory tract infection, which caused a lot of problems to her. The physical deconditioning, weight loss following acute illness, so fall phobia and various these things. So intrinsic factors are these. So when we are going to modify the multiple, we are going to assess multiple risk factors. So these are the intrinsic risk factors, and the extrinsic risk factors are medications, polypharmacy, the sedentary lifestyle and lack of exercises, and environmental factors. There are steps into the door. There are steps to enter the house, and she has like a squatting type toilet, no grab rails, and few rugs as well as excess furniture. So now in the summary of this patient, actually the assessment wise, if I go back, so you have realized that you have to realize the importance of the details, false history, and assessment of the medical issues, as well as the identify of the multiple risk factors. So this is a teaching capsule. So I would like to look into the basic things. Actually, we know this from the medical school, but we hardly do it. So in the elderly patient coming with falls, definitely recurrent falls, not only single fall, the lying and standing blood pressure is must. So probably I know you learned this in the medical faculty, but I would like to remind you again. So how are you doing so I'm going to a little bit of theory now. How are you going to do the lying and standing blood pressure? So ask the patient to lie down at least 5 minutes on the bed, measure the blood pressure, then ask the patient to stand up, assist if needed, and keep the patient for standing position. The first minute, you can measure blood pressure just after standing. So after first minute, as well as keep the patient standing for 3 minutes. Minimum, you have to keep the patient standing for 3 minutes and assess the blood pressure. And if you feel that from 1 to 3 minutes, blood pressure is falling, if patient is asymptomatic, you can keep for a few more minutes and see whether there's a massive drop of blood pressure. So So when the patient is standing, check whether patient is having symptoms like dizziness, lightheadedness, whether patient is getting pallor or any visual disturbance or feeling weakness, palpitation, those things. So document those things. And then, if blood pressure, systolic blood pressure drop of more than 20 or more with or without symptoms, so it is the postural drop. There are three criteria. Either one is significant as significant finding for postural drop. So more than 20 systolic blood pressure drop with or without symptoms, or drop blood pressure below 90, systolic blood pressure below 90, even if the blood pressure drop is less than 20 with or without symptoms, important. And drop of diastolic blood pressure 10 with symptoms is again considered. So systolic more than 20, diastolic more than 10, with or without symptoms, important as postural drop. And the systolic blood pressure drop is more significant than diastolic blood pressure drop. So time go up test, and it is use the stopwatch. The patient is where, so keep the chair close to the wall, and patient can wear her regular footwear. Patient can use her regular walking aid. So what you have to do, ask the patient to sit back on her standard armchair, and then ask her to walk 3 meters, like 10 feet away, turn back and come back to her seated position. So ideally, the person who is strong and young or patient will do it less than 10 seconds. And there is a video. I think time will permit to show the video. And I will just play the video. This is the YouTube video where you can see. So why I am playing this? Because it is important to you all to know.
Timed up and go test. The purpose of the timed up and go test is to assess the mobility, balance, walking ability, and fall risk in older adults. The test measures in seconds the time it takes an individual to stand up, walk a distance of 3 meters or about 10 feet, turn around, walk back to the chair, and sit down. Demonstrate the test to the individual and use a stopwatch if you're able to. The individual should walk a safe and comfortable walking speed. The test ends when the individual sits on the chair. Speak slowly and clearly. Your instructions might sound like this. When I say go, you will stand up from the chair, walk to the mark on the floor, turn around, walk back to the chair, and sit down. Tell the individual to walk at a comfortable and safe speed. I'll be timing you using a stopwatch. Ask them if they understand the instructions and start the test. You might find it helpful if you use a cue like ready, set, go. No physical assistance is provided.
Okay. We'll go to the next is the Burke's balance scale, where the any patient who is with excuse me. Next slide. The Burke's balance scale is the next slide. Right, sorry for that. So the Burke's balance scale is very important. The patients who are having the recurrent fallers, as well as the patients who are having the problems of gait and balance. So in Burke's balance scale, our patient, we did it. So it assesses like many factors of sit imbalance, stand imbalance, dynamic balance as well. So you can just see these things. The videos also there. I'm not giving the video. I'm not showing the video because it's about 10 minutes time video. So just see the Burke's balance scale, how you're going to assess. And the vision assessment. So the Royal College of Physicians has given the bedside visual assessment check for falls prevention. Mainly in the bedside visual assessment, what we look at is whether the patient is having the first three questions. Usually they ask any patient who mainly had falls or even without falls. So what we ask about her vision, whether she's used glasses. The second question we ask about the distance vision. And the third question we ask about the near vision. So they use this graph to assess near vision and as well as distance vision. The last two questions, like question number 4, basically assess the peripheral vision in all 4 quadrants. What I have given is the clock, the clock drawing, and ask what is the time. So with this sort of clock drawing, we can assess whether all the peripheral parts of the vision is intact. And the last part is eye movement. With the using of this red stick, all the vision can be assessed. So this sort of thing, it can be done bedside. So very important in the elderly patient with falling to assess the near vision, distant vision, and ask about his or her visual issues as well as peripheral vision and eye movements. And review the medications. This is very important thing. So our patient had the polypharmacy. So patient was on about 17 drugs, which is with the evidence-based medicine. We used to tend to give a lot of drugs to patients. And the important, how are we going to assess the review medication? This is a separate lecture, but related to our patient, I will just show you how we have done it. So first is obtain the medical history and the condition of the current medical issues. And then list all the medicines and check whether there is indicated or not, and use always document all these side effects interactions, as well as use stop-start criteria to review start or stop medications. So our patient, when we obtain the medical history of our patient, current status, you can see patient is hypertensive patient, patient's blood pressure was 100/60, the standing was 80/50. So definitely she has having postural drop. So she is diabetic and her blood sugar was 76. She has OAs of knees and pain restricting her mobility. She is ischemic heart disease, but currently she is not having angina. She is chronic heart failure and she is having exertional dyspnea with mild to moderate exertion. So the disease-wise heart failure is bit active, and you can see most of the diseases are under control, and even the control is too much to cause side effects. And when we review the medicines, this is the way we have to do. We list all the medication, 17 medication, I have listed according to the indication. She's hypertensive, she's diabetic, she's ischemic heart disease, chronic heart failure, OA, and so according to these things, when I put the hypertensive medication, you can see she's on 4 antihypertensives. Out of that, she's on 2 calcium channel blockers, diltiazem and amlodipine. Further, she's having chronic heart failure. She's on furosemide. You can see she's on HCT furosemide both. And she's diabetic with blood sugar of 76, and she's on metformin and glycoside both. Further, she's on insulin as well. Ischemic heart disease, she's on atorvastatin, ISMN, aspirin, clopidogrel, GTN, all. And she's currently not having angina. She's having OA, with various deformities, she's getting glucosamine and sulfasalazine, and she's having omeprazole, but there's no gastritis or GORD. When I review all these medications and with the current side effect profile, you can see I have reduced the drugs. The hypertensive medication, which helped to we reduce up to losartan, which only giving losartan alone, actually the postural drop disappeared, and gave furosemide because of she had mild ankle edema and heart failure issues, and just change all the other diabetic medication, just keep metformin and dual antiplatelets because she has no angina for a long time to single aspirin, and statin continued, GTN just kept. And she had the problem, she had pain of knee joints, so I added naproxen for her, and she didn't have any gastritis, so omitted omeprazole. So 17 drugs brought down to 5 and 6 drugs. So this make the drastic difference in her management. So medically, what I did was the inappropriate polypharmacy I addressed, and medication review I reduced. So this, I improved her medical condition, I improved the side effects profile of the medicines, as well as parallelly with physio and OT's assessment, social workers help, we did exercises, nutrition, as well as the other necessary home environmental modification. She improved, and she living independently without any falls for last 5 years. And further we did, so further very important thing to do in this sort of patient is assess the osteoporosis risk, fracture risk assessment as well. So DEXA scan is very important before recurrent fallers, as well as the FRAX-score, fracture risk assessment tool is validated to Sri Lanka. It's available online. Please do FRAX-score for recurrent fallers. Further, any patient, if indicated, we have to do the mini-mental state like cognitive assessment, do AMTS or mini-mental assessment, and we can use the functional assessment, Barthel Index, extended the assessment, extended activities of daily living. There are various sort of tools we can use to assess. Right. So in summary of first case, the patient with the recurrent falls with polypharmacy, inappropriate polypharmacy, she had gait balance issues, she had the other nutritional issues, as well as those things. With the multidisciplinary team, help of multidisciplinary team, we were able to improve her outcome. Basically, the medical people, myself and our medical officers, we lead the management, as well as with all our effort, we were able to improve. So what I do is case number 2, and I would like you to write down this case, because I am not going to discuss this case. This case scenario 2 is exercise, because it's exercise to you. So patient with a 76-year-old woman who lived independently in her home and brought to the emergency department after one fall at home. So when I assess falls in this patient, there was no past history of falls, and she had hypertension, and she had chronic back pain, which she was taking PRN paracetamol, and she was on amlodipine 5 milligram, and she had chronic urgency, that is overactive bladder, and occasionally she had incontinence. So in this patient, 76, lived independent, and no past history of falls. The young, strong patient with a good BMI, average BMI, one single drug for hypertension, not much of comorbidities, and she had urge incontinence. She experienced increasing fatigue and shortness of breath over last 2 to 3 days. So she developed fatigue, shortness of breath, last 2 to 3 days duration. No other symptoms. She didn't have chest pain, no palpitation, no dizziness, no vertigo, no focal neurological problems, nothing. She was okay, except increasing fatigue and shortness of breath for 3 to 5 days. So this is significant because something is happening. That's why she's having shortness of breath and fatigue over last 2 3 days. And she's a widow and remained physically and socially active. And her daughter lived nearby. She's helping her. And physical examination, she had mild ankle edema. Her heart rate was 100 and her blood pressure was 100/60, and there was no postural drop. There was no postural drop, and respiratory rate was 24, saturation was 94 near. She had systolic murmur at mitral area, and she had bilateral fine inspiratory cackle at base. So all these things come together. Had mild edema, bilateral inspiratory cackles with some murmur, bit of tachycardia, and what we thought is whether there is some cardiovascular problem is happening. So she had a single fall with worsening fatigue and shortness of breath. We did the basic investigations, and this is the ECG. This ECG, any of you can interpret easily. You can see she had Q waves as well as the ST now is coming down, bit of ST depressions. So she had the problem for last 3 to 4 days. She didn't have significant chest pain, but worsening SOB, had a single fall with worsening SOB. So this woman who was living alone, very active, had a single fall this time. So she's single faller with an acute event of myocardial infarction, which lead into, so her troponin was also elevated, leading to a single fall. But for this sort of elderly patient, she had some problems, so which I actually mentioned the previously. So previously healthy, but she's hypertensive, she has incontinent problems, and she lived alone, but coming with single fall. This sort of patient, again, qualify for multiple risk assessment as well as intervention. She needs the treatment for acute myocardial infarction. She needs treatment for the chronic heart failure, as well as she needs the multifactorial risk assessment, which I have mentioned for the first patient. So I keep this for you to as exercise. So with the use of the previous knowledge you gained during my first case presentation, I ask you to do the necessary risk assessment as well as do it as an exercise. So in summary, the falls are common in elderly, may lead to injuries and decline function. The evaluation should include identification of risk factors. So it is gait, home assessment. So medical paternity, we have a lot of things to do. We have to do the postural blood pressures. We have to do time go up test. We can do visual assessment. So unavailability of multidisciplinary team is not an excuse, because we as the medical officers, we know a lot of things, like we know a lot of assessments. We know how to assess joints. We know how to do postural blood pressures. We know how to do time go up test. The even balance, the Burke's balance. It's very simple. These things available online. Anybody can go through these videos. So if we do individualized multifocal risk assessment, and we do the appropriate interventions like the sending for exercise programs, like medication reviews, I think we can improve the occurrence of incidents of falls. So we can prevent falls, like secondary prevention, as well as the patients having problems, gait mobility. If we do all these things in our part, that will be really helpful. So from this, I would conclude my talk, and I think you have gained something, or you have actually your knowledge, you refresh your knowledge. And the most important thing, I think probably our geriatric registrars as well as the trainees, diploma trainees probably listening. So if you, as well as all the listeners, if you can incorporate these things into your practice, you can do a better thing to our elderly population. Thank you very much.
Thank you very much, Varna, for a very informative lecture. And can we take one or two questions?
Yeah, if there are any questions, we.
Right. Can I ask one question, Varna?
Yes.
Because you stressed that multidisciplinary intervention is crucial managing a fall. And when you're working in a hospital setup, and you know that we are lacking the facilities, but I think as a geriatric society, you may have any initiative to improve this multidisciplinary approach to prevent fall. Have you had any program or anything?
Yes, actually, the currently, I think Sri Lanka Geriatric Association, as well as the Specialty Board in Geriatric Medicine, I think the PGIM, so far we have trained 7 batches of doctors, diploma holders. Currently, only 7 batches finished their training. They did 1 year comprehensive training on geriatrics. So they have spread across the country, and they can start the leadership. I know when we go to the hospital, the major hospitals, we have physiotherapists, we have occupational therapists. When we go and talk to them, they definitely help us. That's how we did it. Because when we ask, if we lead, definitely we will be able to get the help. Further, the PGIM has started the MD geriatric program, and the first 2 geriatric registrars had their exam yesterday as well. So about 3-4 years time, we are getting a Sri Lankan board certified geriatrician as well. Meanwhile, as doctors, this is basic things we can lead, as well as I said, multidisciplinary team may not be available, but what they are doing, we can ask for help. If it's very difficult to get the help of multidisciplinary team, what we can do is these scales, as well as how these perform, is in online. We can get the online resources. So if you are really interested, we can do it.
Thank you very much. That's a very good news for the Sri Lankan medical profession as well. So in the absence of a question, let's wind up the teaching capsule. On the behalf of Ceylon College of Physicians, I would like to present this token of appreciation to you. Thank you very much, Varna.